Good evening, everyone. Thank you so much for joining this episode of Probably Nothing. I'm Athena Lamnasos. I'm the Chief Executive of the Eve Appeal, and we run this online series every Tuesday looking at different issues and aspects that impact on gynecological cancers and their diagnosis. As a charity, our focus is on prevention, risk prediction, and early detection. And something that people are aware of, or increasingly aware of, is genetic risk and genetic predisposition to develop cancer. Now, what's really important to remember is you don't inherit cancer, you inherit a risk of the potential and an increased risk to develop cancer. And one mutation that many people might have heard of is called the BRCA gene. And we all have BRCA genes, but some people have mutated or changed BRCA genes, and that has an impact on their risk of cancer development. We talked a lot about this last week, and we wanted to bring in a patient perspective on what it means to find out your BRCA status and what it means if you're then diagnosed with cancer. So it's a great honour to introduce Alison Daigle to you. Alison is a patient. Hello, Alison.
Hello.
Alison is a patient who is, I don't know what you can say, really. You know, you've got the double whammy, haven't you? Not one cancer, but two diagnosis. And thank you so much for talking to us this evening and talking about the kind of impact of this diagnosis, but particularly the impact of finding out about BRCA and hereditary risk, and what that's meant to you. So fantastic to have you. And I just wondered if we could start off, Alison, with you telling us a little bit about how you were diagnosed and when the first time was that anybody mentioned genetics to you.
Sure. So I was originally diagnosed with breast cancer in June 2014, and I had probably 8 months of lots of other issues with pains, etc. And I'd had scans and I'd been told to go away, that there was nothing wrong. So we wound forward 8 months and I ended up being rushed into hospital for breast surgery. And basically, during the surgery, they discovered that there was something very wrong, and more tests was done. And 2 weeks later, it was discovered that I also had ovarian cancer. And so it was like the double whammy, as she said. It was like terribly shocking. Didn't know what to think. It was basically stage 4, metastatic, and very bad news. So once we knew I had ovarian cancer and breast cancer together, the oncologist instantly talked to us about BRCA and sat us down and talked to us about the implications if I was a BRCA carrier, what it meant, how it was inherited. We had one of his colleagues come to us to ask for family history and take blood tests, and again explain very carefully what it meant, how if I was a carrier that it then would or could affect my daughter. So it was quite a lot to take in one go. And so yes, we were mentioned. It was very quickly about being BRCA. It was instant. It was very obvious. I mean, I know now, as soon as you say breast and ovarian cancer, it was highly likely that I was a BRCA carrier. That's what happened.
Yeah, I mean, it must have been entirely shocking. And how much had you heard of the BRCA gene mutation before you were told you had it, or did you have any awareness of it?
Yes, because I knew about Angelina Jolie. And
okay.
But I knew from Angelina Jolie that it was down her maternal side. It never, it didn't really, I didn't think it affected me because I'd had regular mammograms. I'd always told them about the history on my father's side. And every single scan I had, they all told me it was irrelevant because it wasn't on my maternal side. So that didn't help. So no, I never felt that I was at risk. Nobody told me I was at risk. My gynecologist didn't tell me I was at risk. Nobody knew. There was just nothing.
And I think that's a really, really important piece of information, isn't it? That genetic, genetic risk can pass down through your mother or your father, and indeed, you mentioned your daughter, but of course, it could pass on to sons. It's something that can occur in anyone.
Mm.
And you hadn't been aware of that before.
Yeah.
So, well, first of all, tell me a little bit about how did finding out that you were BRCA positive, how did that affect your cancer treatment? Did it change things for you? Did it make things easier or more difficult?
What I would say, when you're a BRCA carrier, the doctors seem to tell you that it allows, it's sort of irony that being a BRCA carrier can help you respond a little bit better to treatment. So we were told that, but we were also told that there was new treatments coming through specifically for BRCA carriers, and it hadn't yet been approved because I was diagnosed in 2014. So PARP inhibitors were being talked about. They were on trial, and my oncologist said to me, this is what he wanted me to get on. This was what it was vital for me to get on as a BRCA carrier, but he had to get me there because it wasn't approved yet. And that's where we started from almost day one. When I started chemotherapy, that was the discussion. You need to get on the PARP, and I didn't qualify for a trial because I had breast cancer as well, which didn't help. So yes, he was very he was very informative and very pro these PARP inhibitors. So I did know about that, and that was the aim, really. That was his aim,
Yeah,
keep until I could get access to this PARP inhibitor.
yeah. And we'll bring in our nurse Tracy Miles later on in this session, who'll talk a little bit more about PARP inhibitors. But you were actually diagnosed at a time of huge change. I mean, as you say, the treatment for ovarian cancer was still very much and PARP inhibitors was very much in clinical trial phase, and you didn't qualify for those because of the breast cancer diagnosis. But actually, you have really benefited from that treatment, which has been which has been very, kind of like, very, very positive for you.
I've been on it for 4 years. I've been on olaparib for 4 years exactly. I
Yeah,
mean, it's remarkable. Yes.
yeah, yeah, fantastic. So you mentioned your children, and of course, the thing that comes along with finding out your BRCA status is, worrying about the people around you. So tell us what happened there. So you found out that you were BRCA positive. What then happened,
What did
and
we do next?
what have the implications been for you? Because that's what people always talk about. It's the kind of what next. You get this information. You had already been diagnosed with cancer. Many people find out about their BRCA status when they're not. They're well. They don't have cancer, and it's what did you do with that information, and
So
what were the first steps that you took?
the first thing we did was test my father to
Uh,
confirm what side it was from, because he was
mm,
89,
yeah.
and we wanted to confirm that it was from his side so that
Mm,
we could protect the rest of the families if we
yeah.
knew what side it was from.
Yeah.
And then my daughter, who was I think she was 24,
Mhm.
wanted to know whether she was a carrier or
Mm,
not.
mm,
So
mm,
she tested it basically at the same time.
mhm,
So that
mhm,
was the first things we did.
mm,
And then once we knew it was from my father's side, we could then let the family and all the cousins know. And I think today it's done slightly differently, because I think the genetic counsellor will write letters for you. We had to do all that. It was very different.
mm,
I think it was
mm,
a lot harder when we were doing it. It was hard to get testing. It was hard to do anything, really. And now
mm,
today, testing is much easier. Testing, more people understand what BRCA is and what its
mm,
implications were. But when it came to my daughter, my oncologist was fantastic, because he arranged for her to be scanned, to be checked, and was helping. And I also had a counsellor who was doing the same once she knew that my daughter was also come back positive. Because I was totally heartbroken to find out that she was carrying it as well, because we not only had obviously my cancer going on, we now had to worry about her and what were we going to do, because as a mother, all I could think about was keeping her safe. But at the same time, I'm convinced that she's driven me to get through this treatment, because my thing was to be here for her treatment. Because originally I was told it wasn't possible.
A whole very tough set of things to think around. And your poor dad, I mean, how had he heard of the BRCA gene? Did he have any awareness?
No,
and did he have any awareness in his family that anyone had? No.
His sister had died of breast cancer at 52.
Right.
And I never gave it thought that it could be hereditary, because my mother always said to me that she'd been on the pill, and she felt, was one of the first people to go on the pill, and she felt that it was the pill that caused her breast cancer, not that it was familial.
Right.
And my grandmother, so my father's mother, apparently had had a double mastectomy. He'd never even mentioned it, because they didn't talk about cancer back then. It just was the big C, the dirty word. So I had absolutely no idea until I had cancer, and I sat him down when we had to fill in. You have to fill in a form for family. I said, what did Grandma die of? Because he would say, oh, she's riddled in cancer and she just died. Never knew. So obviously, once we saw that not only had my aunt died young, she was 52, but my grandmother around 60 had died of breast cancer, and she had stomach pain. We had to presume that they both were carrying the BRCA gene, but my dad came back carrying the BRCA1 gene. So we knew it was from him.
Right. And in terms of your daughter, so you were going through treatment, and then you were holding her hand as she went through testing, and then made decisions about what she was going to do going forward. And I suppose one thing we should mention here, and again Tracy can talk a little more about this, is that the pill isn't something that greatly increases your risk if you're a BRCA carrier. So taking the pill actually can have preventative qualities, because it reduces the number of ovulations that your body's exposed to. But Tracy can come back and talk about that. But it's very easy to understand why people have got a huge range of fears about hormone-associated cancers, and whether it's IVF or HRT, or indeed taking the pill as a contraceptive. People have got a lot of worries about whether that increases your risk and what you should do. But tell me a little bit about Gaby and the kind of the steps and the decisions that you went through with her.
It was very hard. I mean, from the moment she found out, and she wasn't really told in the kindest way, because the geneticist phoned her and she was in the park. It wasn't really an ideal way to suddenly, even though she knew she was, it was like you sort of need your hand. I think you need to have your hand held. But she'd already she made her decision that she was going to have the mastectomy ASAP. So she was only 24, and we took her to see obviously my surgeon and some other surgeons, just to have opinions, and the opinion was to wait a couple of years, but she must have it done by the time she was 30. And I mean, it's such a huge decision. It's not taken lightly. It's it isn't a boob job. Some people think, oh, it's it's a boob job, but it isn't. It's you have your breast removed. It's a huge decision, and she very bravely, and I don't know the words to say it, but she made the decision, and she had the surgery when she was 26. So she was young, very young and very delicate. And but she said it was the best decision she could do because she knew she had to have it done by 30, and what was the point in waiting?
Yeah. And that would have given her peace of mind and obviously reduced her breast cancer risk enormously.
It reduced it from something like 85% down to under 3%. I mean, why wouldn't you? I mean, that's it is a huge decision for any woman.
And were there any other decisions that she made at that time, or are you still going through the process of making decisions around how she can best protect her health?
So no, we're still going through it because she's now turned 31. She's being too young. When under 30 or too young, they don't want to really check your ovaries. They don't. There's no trials. There's no set rules or doctors who are particularly watching you when you're so young. But once you know you've got this BRCA carrier, you sort of want to be cared for. But now she's been enrolled on a trial called the Protector trial, which opened up for when she was 30. We've just joined it last year because COVID delayed it. So now she'll have to make the decision to either remove her fallopian tubes, and hopefully it will allow her to delay the removing of her ovaries completely, which will delay menopause for her, which would be better. But she has the other issues to think about. You've got to think about maybe egg freezing if you haven't had children. You can still have a baby, which I never realised without your fallopian tubes. You just have to have IVF. But she's chosen, if she has a baby, to have IVF because you'll have the PGD.
Okay, and again, we can bring Tracy in to talk about that, but explain a little bit what PGD is, because lots of people who are affected by BRCA are thinking about that as an option now.
So PGD is the easiest way to describe it is a form of, it's basically IVF, but once they have the embryos, they will check the embryos to see if any of them are carrying the BRCA gene. If they're carrying the BRCA gene, they won't use them, but they'll only implant any that aren't carrying it, and they'll check them for disease. Which means, as we say, we can stop this deathly inheritance, like dead, basically. So we can make sure she's not going to pass it on. It's a fantastic way to stop it in a family. But it's hard, it's IVF, it's very hard.
Really hard. Really hard.
It's a hard decision to do, and she hasn't done it yet.
And I mean, it is a really hard decision, and in some ways, kind of easier for your daughter going alongside you in terms of you finding out so much and being able to pass it on. But where have you gone to for information? Who have been the best sources, or the best sources of support and information, and who are the different people within the NHS and the health system, the broader health system, who have been supporting you?
Difficult question. I mean, from day one when I was diagnosed, there was very little help. I would say Facebook was fantastic. I'd never joined it, and you found other women going through what you were going through, other BRCA women. There became quite a very cute community for young BRCA carriers as well as my age, and we all sort of gelled, and it was very nice, and we all met. So that was really good for support for all of us. Girls who've had surgery were supporting girls that were going through surgery, and that's worked brilliantly well. Today, the charities like the Eva Pill, you have got fantastic support. You've got knowledge, you've got information. What do you do? And that's what's really, really important, because you don't really know what to do. You are given, obviously, this cancer diagnosis, and you've got to deal with that. And then you have to deal with the BRCA side of it. And that you have to go through genetics. When Gaby was first going through it, we went to, can I name the hospital?
Yes, of course.
Went to UCH, who looked at her ovaries and said she needs to see the genetics, referred to genetics. This was through genetics. Was it through genetics? And then they said to us in their genetics, no, you don't, you're not the area. Then she got referred to the Royal Free, and again, They said, no, you're not our area. It was a lot of hard work, and eventually we got to Northwick Park. And everything does, most things seem to have to go through a genetic counsellor. If you want to have a PGD, you've got to be referred. If you want to see a breast specialist, you have to be referred. Everything. So it's quite hard work. But again, we haven't done it for a little while. To get her onto the trial, the Protector trial, we'd registered for it. And I just happened to be at Hammersmith for an appointment. And they sent her a letter to say it was open again. And we were at Hammersmith. And we phoned them. And they put us in while we were there. We said, right, we're here, let's do it. And that's how we got on the trial very instantly. And that was only last December.
Well, it's fantastic to have got onto that. Thank you. So all of the kind of navigating of the system has really been quite challenging, and you know you're a very knowledgeable patient in this area, and it's something that we pick up all the time, people feeling quite sort of bewildered by the system and all the different stages and all the information that they have got to process. So thank you very much, Alison. We will bring you back in, but I just want to bring in Tracy now. So if I can just introduce Tracy Miles. Many of you will have seen her before. She's our nurse specialist and works as part of our Ask Eve information service, where we do take a lot of calls and inquiries, don't we, Tracy, around genetic risk. So just listening to Alison's story there, what is it that kind of jumps out at you that people most need to know and take note of so that they find it slightly less bewildering to make their way through the system?
Thanks, Athena, and good to listen to you, Alison. You tell the story really well, and actually what you described brilliantly are two separate sort of niche areas. So we've got, and the terminology we use is diagnostic testing. So that's for the patient that Alison, so the patient who has a cancer, and the doctors, clinicians are wondering, I wonder if this is due to an alteration or a mutation in my patient's genes. So that's what's called diagnostic testing. So that set of information is very different to the predictive testing, which, Alison, you described so well that your lovely Gaby went through. So that's where you have a patient like mum, like Alison, whose children, could be son or daughter, are wondering, I wonder if I could carry an alteration in my gene. And as Alison was telling us, you know, she inherited and they got dad tested. And so we know that if we have a patient with an alteration or a mutation in their gene, there's a 50% chance of it being passed on down. And as in Gaby's situation, she did pick up the gene, not unsurprisingly, from her lovely mum. So in answer to your questions, Athena, so diagnostic testing are patients that call in to Ask Eve, and they want to know about, they're going to their GP or they're going through testing to see if they've got a cancer, an ovarian cancer, because that's suspected. Our patients need to know that their doctors, their clinicians and nurses should be doing what happened for Alison and should be having a BRCA test done as part of the diagnostic process. And that's changed actually quite a lot from when, you know, when Alison was diagnosed, not that many years ago. Feels like forever, I know, Alison. So every woman should be offered, pretty much every woman being worked up for ovarian cancer, at least 80% of women. And if they're unsure, please do call in to Ask Eve or email us.
So that's a very important point, Tracy. Yeah. If you're diagnosed with ovarian cancer, what should you be asking if you haven't been offered genetic testing?
You should be asking, you're working me up, you think I have an ovarian cancer. I have heard that women should be tested for the BRCA alteration. Can you tell me, doctor or nurse or combination, why I'm not being offered that test? Now, it might be there's about 15 to 20% where it's not as relevant, and that will be the answer. And that could satisfy our patient. She can still call in to Ask Eve to talk it through. If there is an answer, well, we don't offer testing, I'm afraid that's an answer we don't need to accept anymore in the NHS. And once again, our patient can call in to Ask Eve and we can give more information. And actually, top tip, on our website, we have a whole piece of work that we've done about ovarian cancer testing and BRCA, and it was done by clinicians and patients. In fact, Alison helped us. So please do feel that, you can look at that on our website.
Okay, thank you. And then I think it's really important to touch on what happens when you find out you are BRCA positive and you haven't got cancer. Who is it that helps you there, and what are the steps that patient who isn't ill and has just found out something, entirely life-changing, what is it that they will then, what are the steps for them? Who do they see and what are they advised?
Okay, it's a really good question. So it shouldn't just be your lovely mum called Alison. So in
No.
Gaby's situation, of course, mum and dad and the rest of the family are there to support. But equally, it should be the genetic counsellor in this situation. So as Alison described, it was a story of getting a call in the park. Do you know what I think we should also get our patients to do? So like in Gaby's situation, talking to the genetic counsellor, because the counselling will have been done in clinical genetics, as Alison said, for the predictive for this patient without cancer. So the important thing for the family and that patient to do is to manage expectations and to say to the genetic counsellor, when you return my results, I would like to see you. I would like you to send me a letter. I would rather have a telephone call. So decide how you want to receive your results. That's really key. We hear that story too many times. I was in the park. I was at work. I wasn't expecting the call. Not good enough. And actually, clinical genetics are wonderful people. Don't get me wrong, but it's how we work with them. The other thing I think is, how are patients going to manage with the news that they get? That actually starts before, once again, getting the news. When you have your genetic counselling, if you feel you've got enough information to receive that phone call or that letter, let your clinical genetic counsellors know. If you're not so sure, then let them know too, because quite often, if we say, yeah, no, I've got it all now, that's fine. Actually, we don't have to please our clinical genetic counsellors. They will give you a good hour of counselling, and more if you need it. So it's about managing expectations. Once again, if you get your information and you're still not sure where to go with it, Ask Eve don't necessarily have all the answers, but we do know where to signpost you to. So please do call or email us if you need to.
Yeah, thank you. And where is it that the genetic counsellor normally sits? In what part of the NHS?
Okay. So actually, that's a really good question in the role that I'm doing now. So as well as working with gynecology, we have clinical genetics departments, which are, and it's called clinical genetics, very discreetly separate to a gynecology department or a breast department, for example.
Right.
So it's a discipline, if you like. What's happening now around the country, there are 7 new regional, they're called genetic medicine service alliances, where actually we're doing, the buzzword is often called mainstreaming, where rather than having to go to clinical genetics, if you're a patient receiving cancer treatment, you can actually have your counselling and consenting done whilst you're being cared for by the hospital. So as Alison experienced, but it's a completely separate discipline, clinical genetics, and they sit usually within a hospital building. So they sit within a hospital campus, but they are completely separate to a surgical or medical breast or gynecological department.
Yeah, got it. And that's often quite a shift for patients to understand that it is something completely separate.
Absolutely.
Thank you. Now, I don't know if there was anything else that really struck you from Alison's story, but I thought it was worth pausing on that kind of misconception about the pill, because, we're often asked about kind of different sorts of hormone disruptions and people worry terribly about what they've caused and how they have influenced a hormone associated cancer. But actually the story of the pill is very underknown as a protective factor. So it would be very useful for you to talk about that, Tracy.
Yes, you're absolutely right. So actually the pill is known as chemoprotective. It's not a chemotherapy as in how we think about drugs for cancer, but it's actually chemoprotective in that, as you were telling us earlier, the pill actually stops ovulation. We know that less ovulation during a woman's life before she reaches menopause actually protects her, gives her some protect from getting ovarian cancer. So a woman who has more than one child, 2, 3, each child, of course, she doesn't menstruate for 9 months while she's pregnant. So the pill actually tricks us in a sense. So we don't ovulate. So it's actually protective. So taking the pill is not a negative thing. And it's not with that question when a woman gets ovarian cancer, is it because I took the pill? Absolutely not.
Yeah, thank you. I think that's a really important point to kind of to drum home. And do you want to say a little bit about HRT risk, which is something else that people really worry about, and then IVF risk as well? So all of those kind of main hormone disruptors, do they increase the risk of developing breast and ovarian cancer, particularly if you're at high risk anyway, so you're carrying a mutation?
So with HRT, with breast cancer, with a small proportion of women who've had breast cancer, and this is where she needs to discuss with her clinician, if it's an estrogen-dependent cancer, then there's the potential that that could cause problems. So it's done very much on an individual risk. With ovarian cancer, no, this isn't going to give her any more risk. And so once again, it's done on an individual case-by-case basis. With IVF, we've heard a lot at the Eve appeal where there's a suggestion that IVF may cause ovarian cancer. Now, the jury still remains out completely, depending on which scientific paper you read. However, if you think about it, we look at screening, and that's one of our big things at the Eve appeal. We don't want those cancers to occur. Now, IVF, in a sense, a woman going through IVF is having a type of screening in that she has her ovaries looked at, screened by ultrasound screening, far more than the woman who isn't going through IVF. So it's not unsurprising if you see that we might pick up a few more ovarian changes simply because she's being looked at, screened, ultrasound more often. There is another thing with IVF where some of the drugs that women are given to support them and to help them ovulate during IVF may cause a predisposition or a potential change in the ovarian capsule. But there's no hard and fast science. So it's a really tricky one to answer. So I hope that's given you a bit of sort of balance of both sides there.
Yeah, thank you. Thank you. And we're coming to the end of our time. It'd be lovely just to bring Alison back in to say goodbye. And thank you so much, Alison, for telling your story. And I'd just like 2 words, a couple of words from each of you, really, on if you knew that someone was at high risk or were worrying that they might be, what's the advice that you would give them, Alison?
I told them to read the blogs.
Very good.
Also use it. Yeah, I tried to be quite tactful. Some people don't want to hear anything. If I've done a talk we've invited them with and they've gone away and thought about it. Yeah. And a couple of ladies have listened and gone straight to their doctor. And interestingly, a couple of people, I know a lady whose mother had ovarian cancer and didn't feel she was at risk and went to the doctor and she had discovered she already had breast cancer and was BRCA. So that's the thing, is you've got to try and persuade them to
I mean, I think the phrase you always use is knowledge is power, and I think that's
definitely knowledge is power. Not head in sand. Knowledge is power.
Yeah. And what about you, Tracy? What would you say to someone who was worrying about being tested?
So I really like the knowledge is power, and then I would add to that, and we have the way to support you using that knowledge. So it's science meeting emotion. So the science will give you the knowledge, you'll get the test. And then, as Alison has brilliantly eloquently described, the emotion that meets that science and what you do with it. So you get the knowledge, and then the power of supporting your emotions to the power of that knowledge. And I think it's absolutely the right way to go to get tested, but you need support through both. It's emotional and an intellectual challenge.
Yeah, yeah. It's not a walk in the park. You need support through that, and it needs a lot of thinking through. Look, thank you very much, Tracy and Alison, and thank you all for joining us this evening. We've got a lot of information on the Eve Appeal website around BRCA inherited risk, hereditary cancer issues. There are a number of different areas and signposting to different sources of information. We've got a very comprehensive guide around BRCA and ovarian cancer. So do head over to have a look at that. Keep your questions coming in to Ask Eve, and we will always come back to you with expert information, evidence-based information, and we will signpost you to other sources of information if you want to know something which isn't squarely in our area. Because what we do know about BRCA is it's like lobbing a kind of big brick into a very calm pool. There are endless ripples, and there are lots of issues that relate to it. So thank you very much for coming to us this evening, and do come to our website and our social media channels and find out more.